Hello and welcome to this King's Fund online event on artificial intelligence in healthcare. My name's Harry Evans, I'm a researcher at the King's Fund and today I'm introducing a fantastic lineup that we've got talking about this big issue. I'll introduce them in one moment, but just to tell you a bit about how this event will run. We've got a couple of polling questions that we'll be asking throughout the hour, which will be asking for your input on a couple of big issues in artificial intelligence. We also want your questions so I can direct them to the panel. So you'll see that there's an option for you to complete a question, and those will come up on my screen here, and I can ask those of the panel. The final thing is we'd very much enjoy it for you to continue the debate on Twitter during and after. So please use the hashtag KFOnline if you want to tweet about the event. So, as I said, we've got a fantastic lineup of speakers today who are going to be here to talk to you about artificial intelligence and where they think the potential opportunities are in healthcare. Let me introduce them first. So, on the right here, we've got David Cole, Innovation Lead Europe, IBM Watson Health. Rose Gray, Policy Manager at Cancer Research UK. We've got Nick de Pennington, Digital Innovation and Population Health Lead at Oxford University Hospitals NHS Foundation Trust. And finally, Ian Hennessy, Clinical Director of Innovation, Alder Hey Children's NHS Foundation Trust. Now, I'm going to give them a quick opportunity to introduce themselves and give a minute on why they think that artificial intelligence is an important discussion to be had. And then I'm going to go into some other questions for them before we move to the questions from the audience. So, David, can I start with you? If you just want to give me a minute on why it is that you think this is an important discussion.
Yeah, thanks, Harry. To me, artificial intelligence is one of the most exciting areas from a healthcare perspective, and I think a really important change that we're going to see over the coming years. If you think about all the data that's being provided and produced in the world today, we need better insights in terms of making sense of that and being able to put that into the hands of clinicians and other healthcare providers. So it's really about putting the right information into the hands of the right people at the right time, and these technologies and these tools hopefully will enable us to do that.
Thank you, Dave. Rose?
So within cancer, there's lots of different ways that artificial intelligence is important and hopefully going to be more important as the years go on. But I think one thing that's just really important to focus on is thinking about the scale of the challenge for cancer. So 1 in 2 people born since 1960 will develop cancer. We know instances rising, treatments are getting more advanced and more complex, and patients increasingly have lots of different health conditions going on and quite rightly demand a lot from the service. We want to see more personalised care. So for us, we know that the NHS is already under a lot of pressure, and if there are ways that artificial intelligence can streamline aspects of cancer diagnosis, treatment and care, and make sure that every patient gets treatment and care that's tailored to them, then there's a really big win to be had. So that's why we're really interested.
Great. Nick?
I think a combination of both of those answers. My background is as a clinician, as a surgeon. I think as a clinician you can deliver excellent one-to-one care, but the opportunity now as we start to aggregate large quantities of data and start to be able to use artificial intelligence type technologies is to really gain some insights there that previously we just didn't have the ability to gain, and to be able to deliver an impact that's at a scale beyond what we've been able to do so far.
Exciting. Ian?
I'm going to have to echo that. I mean, again, as a clinician as well, it just doesn't seem like there's enough of us. We've got all this data out there and we're just drowning in it right now. It feels like my job at the moment is almost trying to ignore things rather than take into account, because it will make the decision too difficult, because we just can't balance so many variables at the same time. So having a bit of a hand with that ability to get an insight from the data, to visualise it, to put it in a more actually put data in a more human, understandable way, it'd be great to have that.
Thanks, Ian. So I'm aware that this is a really complex issue, it's a really complex subject. So maybe if we could start with an easy question and come to you, David. What is artificial intelligence in healthcare?
So artificial intelligence means a lot of things to a lot of different people, and what maybe some people don't understand or sort of see is that actually we're surrounded by it. So it's in our mobile phones, it's in our cars, it's in many, many different things that we touch and play with on a day-to-day basis. And it's also nothing new. So artificial intelligence has been around for a long time, and it comes in various different pillars, and people talk about it in different ways in terms of machine learning and deep learning, natural language processing, natural language understanding, all of these different things. But essentially they're all underpinned by an algorithm. Now an algorithm in a traditional sense is essentially teaching a machine to do certain thing in a certain way. An algorithm in an artificial intelligence sense is a recipe for how it can be done in much more complicated element, and going through all those different stages and coming out with an outcome at the end of it. The reason, and we kind of touched on it, I guess, in our introductions, the reason why this is so important at this stage, or why it's come to the fore now, is really because of certain few things. One is data. We are surrounded by data. We have so much data, and a lot of that is unstructured data as well. So if you think of it from a medical perspective, the medical images that we've seen coming out, the medical records that we've got, all of the research papers and everything else, how can, as Ian said, how can a clinician actually, even in their lifetime, not just in their training, get a handle on what's going on in that? Mm. So it's helping to put those things to them, and making sense of those things, and being able to understand and bring out the pertinent things. But what it's and the difference between I guess artificial intelligence systems and kind of traditional systems is that they don't get programmed as such. They are taught. So they're taught with a set of data which says what's right and what's wrong, and then over the course of that kind of training period, it understands what it's trying to find. So if you think from an imaging perspective, you show it what could be cancer and what is not, and then you give it that training data, and it can understand it as it comes out. But it's not looking at certainties; it's looking at more kind of probabilistic elements, and that's where it's really important that actually, from an artificial intelligence point of view, it's the clinician and the machine working hand in hand, and almost augmenting the intelligence of the clinician as you're going through it. That's certainly what we look at from an IBM perspective, and to me that's the most important thing that we can see from AI as we move forward.
Mm. So Nick, I mean, for clinicians then, what are the opportunities for AI in health and care?
I mean, I think you could probably break it down into a spectrum. Mm-hmm. And at one end are sort of some of the things that David started to talk about in terms of the specific point solution. So natural language processing, to be able to understand the content of a free text note that you write into a medical record. I think it then moves into a space where it's about supporting a pathway. Mm-hmm. So that could be something like being able to triage images that come out of any form of radiology type imaging system, so that we know which images need some expert human intervention, and which maybe can be confidently classified as being okay or not okay. And then as we kind of pull all those things together, it gets to the point where actually we move to a space where we can automate an element of healthcare delivery, and essentially, as David says, augment what clinicians are doing, but take that whole piece of the care pathway and deliver it autonomously, so freeing up people, which is fundamentally the biggest challenge we have in healthcare at the moment.
What does that mean for patients?
Well, I think it means that there's opportunity and challenge in all this, which I'm sure we're going to get to. I think the opportunity is that healthcare is fundamentally constrained by its workforce and by the cost of delivering it, and these seem to me, at least, and I guess I'm a bit of a techno-optimist, to be opportunities to actually reduce the cost and improve the consistency and therefore the quality of care that we deliver. I think there's an element though around it of trying to help people understand how to go on this journey, but I don't think it's a big bang. We're not sitting today and then tomorrow it's going to be a completely different world. It's going to be an incremental journey where these sort of technologies become part of normal day-to-day care, and I think, as David says, it's prevalent in everything that we're doing in our consumer life. So it's not going to be a great big shock to people.
And Rose, can I ask, from Cancer Research UK's point of view, what role do you see AI playing in cancer care in the future?
It's not an easy question to answer because it is popping up in so many different areas of the pathway. So there's some really exciting work going on, seeing how AI could help certain bits of drug discovery, for example, which as a research fund is very interesting to us. There's also some early research looking at how AI could be used to predict which people and which groups of people are most likely to go on to develop cancer, so they can receive for example, particular health messaging or more frequent screening. There's some really exciting discussions going on about that as well. At the other end of the scale, there is some good stuff about how patients can be supported throughout treatment and be given tools to help manage their treatment, their side effects, and have a good experience of care. So there's lots of different areas, but the one that really stands out to me, and the one that I've seen both the most discussion of and the most concrete progress in, is about diagnostics. So obviously early diagnosis is a massive priority for Cancer Research UK, for the government. The Prime Minister announced a new ambition recently to increase the proportion of patients diagnosed early. And to get there, we need a massive shift in lots of different parts of the pathway, but we need to be testing more, scanning more, screening more, all of that kind of stuff. And all of that means increased resource. But at the moment, I know you said earlier, the workforce is really stretched and 10% of diagnostic posts in the NHS are unfilled. So obviously there's demand there. And as a result, a lot of companies, a lot of academics, CI UK as well, are investing research into seeing how AI could streamline parts of diagnostics through interpreting images, both in radiology and pathology. And I think that's where there's some really exciting progress that's already been made, and where we're likely to see more of a shift over the next 5 to 10 years and beyond that as well.
Yeah, and I think a lot of the focus tends to be on helping clinicians make better decisions, and that's a lot of people with the diagnostics. It tends to be about supporting clinical decision support. But Ian, is there opportunities outside of the clinical relationship to really transform things with AI?
Well, definitely, it's not all about diagnostics. That's why everyone has this image of doctors doing, just sitting there diagnosing all day. But I actually looked at what I did in a clinic, and there's this tiny amount which is actually making a decision and taking responsibility for it, which is kind of what I'm trained to do. But the rest of it was almost hospitality, and then information taking, and then information giving. And that's a huge amount of time that it gets taken up doing relatively simple information extraction and information transfer to a patient. Now, everyone's always said that the gold standard is always going to be information given directly from the doctor's mouth straight to the patient in the clinic. But I don't necessarily believe that. I think there's lots of ways that you can give people information and receive information from them. And if you could crack that with AI, then you would suddenly release an awful lot of clinician time. And also there's a lot of it which is actually quite low level. I mean, there's a lot of information I give which is really just common sense that anyone could give, and it doesn't need someone who's taken 20 years to train in paediatric surgery to do that. So it actually probably make my job a bit more fun as well. So I think I think it's got benefits for everyone.
And maybe David, I could come to you on that as well. Aside from the clinical decision support stuff that often gets talked about, where do you see the opportunities being for AI in health and care?
So I guess there's two things. So Ian's probably being a little bit modest, but one of the things that he's working on is the patient engagement side of things. So actually being able to understand what the patients want, and the clinicians are not always there when you need them. Especially if you, as a parent, your child is taken ill in the middle of the night, you want to get good information from the right sources, or the sources that you are happy to trust. The research engines that you probably go on, but actually what you really want to do is to get some trusted information, and training a system to be able to answer those questions and really kind of understand anxiety levels and do that kind of thing. That is here today, and Older Hay are looking to do that. The other opportunities from a cancer perspective are, as you say, it is decision support, but it's trying to speed up the process of going through certain mechanisms that you need to do. So, for example, clinical trials. How can you identify who is correct for a clinical trial quicker, getting them on there? A lot of clinical trials we see in the press all the time. There are small amounts of people on these clinical trials that take millions and millions of pounds and dollars to put into the ether. How do we make sure that the right people are getting the right clinical trials? And that's something that we're working on from an IBM perspective. We've successfully worked with partners to actually speed that up in terms of actually getting a much greater 80% in some cases success rate about getting patients, the right patients, onto clinical trials. The worst thing for a patient is that they're said, you can have this trial and then at the 11th hour, actually, sorry, we've missed something and you can't have it. It's the worst thing that can happen, in that kind of context. So how do you make sure that those errors are not made and that you can speed up these decision making? So again, it's kind of amalgamation of data and putting that data in, the right data into the hands of the clinicians. They can make the right decisions and we can speed these things up for the patient.
And I think data is clearly key to this. And Nick, you've already said that the acceleration of the amount of data that we've got really changes the game here. What do you think are the biggest challenges at the moment with regards to that data, getting hold of it and using it?
Well, I think we're on a journey towards some levels of data interoperability, which I think is going to be crucial to this, and progressing down that. So I work in the local health and care record exemplar programme that we have in Thames Valley and Surrey, and that and the other population health programmes that's going on across the country and actually globally, I think are key to bringing together data at a scale that starts to make this possible. But the challenges, I guess, around this are about heterogeneity of data.
Right.
And being able
What do you mean by that?
Well, in terms of training systems, I think we need to be aware of the fact that we can easily get down into an alley where we train a system on a data set that is like the people that we look after, and then it's not applicable to another group of people. And so there are all sorts of issues about bias and diversity that we need to capture here. But also, this is costly business, and I start to think of these large-scale, high-quality AI-based systems are becoming, in some senses, a bit like the phase 3 trials of pharma in previous years, where they cost a lot of money to bring together sufficient quantities of data and to then cleanse that data in a way such that it can train the sort of models that we have at the moment. So I think that's a big challenge, and so we do see that there are large companies in the market like IBM and others who are starting to be able to do this, but obviously that does limit who can actually bring these insights forward to the clinical front line.
So we've got a huge number of questions coming in, so we'll move to some of the questions from the audience momentarily. I did mention we have some polling questions, so I would like to ask our first polling question now, and that should be coming up on your screen in a minute. I'll read it out and you've got about a minute or so to try and get your answers in. So the first question that we've got today is, which one of these statements best matches your opinion? AI will bring most benefit to organisations with huge amounts of data. AI has a key role to play in supporting clinicians' expertise and capacity to improve outcomes. The real benefits of AI in health and care will be seen by patients and citizens. AI is best focused on niche problems rather than big complex challenges. Or finally, I'm not convinced of the benefits of AI or we need to fix basic IT first. So if you select the one of those that you think best represents your views, and then we'll go and have a look at the results, and I'll talk through them with you, and then we'll get back to the questions. So we should be closing that poll in a moment. Great. Okay, so it looks like the majority of people, just about 50% of people, think that AI has a key role to play in supporting clinicians' expertise and capacity to improve outcomes, which I hope, given what we've just been discussing, won't surprise any of the panel members. Following that, that 19% of our audience said that the real benefits of health and care will be seen by patients and citizens. So actually, it's possibly a bit reflecting the fact that more people are seeing that this kind of delivers benefits to the system and clinicians than necessarily directly patients and citizens. And then beneath that, 16% of people, the third largest number, said that AI will bring most benefit to organisations with huge amounts of data, which possibly reflects what we were talking about the number of the sheer scale of data that's needed to do some of this stuff. So that's really interesting. Thank you so much for taking part in the poll. We've got another one later on, but I want to move on to some of the questions that you've got. And I think the first one that I'd like to raise, which is from Ian Cross at Hampshire County Council. Now he asks, what benefits might apply for social care? And I think this is a really good question. I think so far we've been quite healthcare oriented, but maybe David, I can come to you to start with. What benefits do you see for artificial intelligence social care?
Yeah, and I think probably Nick will have some good thoughts on this, judging by some of the conversations that we've had. But I think, I guess a lot of the answers that you're going to get today are going to come back to the data. And if you think about all the disparate amounts of data that we have as an individual, actually the ability to bring that together in a social capacity, in order that when you go from your GP to the hospital, or you go to each of the different maybe care providers that you have, and they've got one core record of what you why you've been seen and your ailments or whatever it might be. That is one of the key, and the government is looking at this point in time. That is one of the key benefits of it. Being able to understand when someone has missed an appointment, for example, or has not logged some of the medicine that they should have been taking, and be able to proactively, help them in terms of their personal care. That's another opportunity that we've got. So it's really kind of, we get onto the conversation of kind of monitoring, individuals, and obviously they need to give consent to that, and to, really try and move the care system from the providers to the individual, and to understand what they want to get out of it, and how they can help themselves.
That's great. Nick, did you want to come in on that?
Yeah, I mean, I think thankfully that the distinction between health and care, social care, is being blurred. I mean, clearly it still exists in the UK to a certain extent. I think some of these programs that Leica I mentioned before, are all about trying to join those two systems
local
together.
Health and care record exemplar.
Local health and care record exemplar, so essentially bringing together data across large populations from all parts of the health and care system. I think we recognise in that, and this is where the ability to understand that data in an automated way is important, is that social determinants of health comprise the vast majority of impact on actual health and well-being. And so we've got to bring that into any kind of platform that's going to interrogate the data that's there. I think to be a slightly challenging and controversial, I guess we can push even further more into that consumerized space, and say that all of that the concern about information that we're sharing with the tech companies, for example, that information actually has the potential to be quite powerful and useful for us to inform how to best identify and treat people's health and care needs. So at what point, we're seeing some of the consumer tech companies, Amazon, etc., moving into the healthcare space, and so I think that blurring will continue, and I guess we've got to try and see how that can be beneficial to us, and avoid some of the concerns that people rightly have about data sort of permeability across all contexts.
Yeah, I think that's really interesting, and actually comes on to another question that we've got. In fact, a couple of questions coming in on evaluation, scrutiny, regulation of these algorithms, and how we actually maintain that. And Rose, I know that you've done a lot of thinking on this, so maybe I'll come to you first. So this is from B. Vedha from King's College Hospital. He's a consultant at King's College. And he says, how should AI decision support systems be evaluated before introduction into routine care? How should AI systems be regulated?
I think it's a huge question. I don't have the full answer, and I know it's something that a lot of different organisations are thinking about at the moment. I think there are a few principles that we can say fairly confidently, though, that need to be in practice. I think one of those is that patient engagement is done properly throughout the process, which isn't just a regulatory issue. I think that is an issue across all of this. You need clinical buy-in and buy-in from patients and carers as well. And any system that is done without that, I think, is probably doomed to fail. I think it's really important that things are validated in the real world, rather than just kind of on a very restricted training data set, because of how new a lot of the technology is. I think sometimes you can't. It's a difficult balance between wanting to really get on board with new innovation and do things in a stepwise manner, but patient safety has to be the primary concern. So I'd err on the side of caution when it came to that. And yeah.
Definitely. That's very sensible. Ian, can I bring you in on that one?
Yeah, we're going to have to change the way we think about these systems, because an AI system needs to train to learn. So it's difficult to have it come fully formed out of the box to be able to deploy. It has to have exposure to real life problems and real input so that it can get better, which means you're going to have to get it out there. Now, we already do that. It's called medical school. In training, we don't take people who are completely formed surgeons out or physicians out of medical school. We supervise them and we grade them up. We give them appropriate challenges, and then we see how they do. And so we're going to have to start thinking about things in a way that we are training the AI, and it's not going to be perfect when it first starts. It's going to have to evolve. So, yeah, the way that what the regulatory framework is set up at the moment is that it's got to be absolutely 100%, and this has to be the finished article when it gets deployed. And I don't think that's really going to work with an AI system. And if we totally insist on that, then I think we're actually going to be missing out on something which could be very powerful.
That's interesting. Nick, can I bring you in on that one as well?
I mean, it's definitely not the finished article. I think regulation is going to be an evolving space, and will need to come in to a certain extent. There's the sort of US model of regulation, essentially where we're going to regulate the company, and the company's doing the right thing. Then okay, we'll trust that the AI models are going to be safe and secure. And I think that's there's a place for that to be kind of agile to that ongoing development. I think there's also some issues I think around how the AI-based systems are getting to the decisions that are then driving care, and so something we're going to have to come to terms with is, are we willing to accept that kind of black box, or do we want to go down the route that some organisations are doing, where they're trying to expose their working, if you like? Now, I think to Ian's point, quite frankly, we don't force a consultant neurosurgeon to expose their working about why they decide to do this versus that. But it's a slightly different space that we're in for the technology in terms of the level of security we have for it. And I suppose finding that it's back to the earlier point about the view from the user, the patient, the citizen, about the acceptability of relying on treatment decisions that are not made by this human that you can touch and feel and prod and challenge. And so I think that's going to be something of an evolution in thinking from all of us as citizens about how much, whether we're willing, if the AI-based system decides that actually further treatment's futile, that we're happy to accept that and not proceed.
This is something that I'm really passionate about, and it's also something that's coming up in the questions as well. So Joe Ellens from Senior Fellow at the University of Birmingham asked, to what extent are patients being involved in the development and implementation of AI in healthcare? Is that involvement inclusive of different patient perspectives and needs? So in particular, those groups who might be easy to overlook, for example. So minority ethnic groups is an example that she gives. So maybe Rose, because you mentioned patient engagement first, maybe you can talk about how this is happening already, if it is.
Yeah, I mean, I couldn't comment with much accuracy really, and I wouldn't want to speculate because I haven't been that involved with individual companies or individual projects, but I think there's two reasons why it's important. One of them is about the trust and about the way it's communicated and the buy-in you've got from patients, and it's not even something that's limited to AI. So, there was a huge story about breast screening, about women not being given breast screening appointments, which is an algorithm, but it's not kind of a AI deep learning thing in the way we might think about some of the stuff we're talking about today. So there's that thing, which is just making sure that there's no surprises, and the regulatory elements that are common to all types of technology and decision making. I think the other part is the point about bias, and that's separate, and it's patient engagement more in the terms of which patients are you involving in testing that algorithm. And some of those things are, we know what the issues are. There are, for example, we know that breast density is different in different ethnic groups. So if you're doing breast screening algorithms, you need to make sure that takes into account women from lots of different places, for example. there's some stuff that is new, for example, the genomic medicine side, where it's still quite an emerging field. We don't really know where all the differences are. And I think that's one reason why international collaboration is really important. So it goes beyond the boundaries of the NHS, really. It's quite a kind of global conversation that we need to have.
So it's interesting how public engagement and bias start to become two sides of the same coin in many ways, because you need to be able to overcome the bias when you're designing your algorithm. And in order to do that, you need to talk to patients. But Ian, maybe I can come to you on that question as well. What public engagement, patient involvement are you doing in your work?
So we've made essentially a chatbot that answers really what are basically simple questions about the hospital and coming to hospital and what it's like to have an operation. And that won't work unless you have patient engagement, because it's made by the patient. It's almost crafted by the patient themselves, because we find out what they're asking us, we give them an answer, they tell us if they like to answer or not, and then we tweak it. So it's constantly evolving for the patient group that we are working with. Now, fair enough, you could take what we've made in Aldehay and then it would probably work in most of the UK, but then it probably wouldn't work in North Africa or the Middle East or Russia, because things are different there. But that's the same with me. If you took me and put me into those hospitals, I would also have to adapt. And because I've got a base core, you'd be able to start moving off from there. So for these type of platforms, you can't do it without patient engagement. And that's actually difficult because you have to get it out there when normally it's at a very early stage. But it's the same with medical students. I mean, I have lots of medical students in my clinic, and I always ask patients to come in, is it okay if my medical student sits in, or is it okay if they ask you some questions? I've maybe can count on one hand the number of times people have said, no, I'm not happy for that to happen. So I think it'll be interesting as we start to increasingly train these AI systems in live clinical scenarios.
Yeah, and I suppose there's an interesting question about, going back to our polling question, where a lot of people recognised the benefits for the organisation as opposed to the individual, whether or not the focus is being placed on the organisational engagement. And actually there are some questions coming up about how this can make an impact to patients. How can AI actually deliver for patients? And one example which is coming up has come up a couple of times is this idea about individualising treatment for patients with long-term conditions. So can AI have a role in personalising treatment? So David, maybe I'll come to you on this question. So it's from Nicholas Cole, West Hampshire CCG, and he's asking, how does the panel feel that artificial intelligence can help provide individualised treatment to patients with long-term conditions, particularly when used in conjunction with patients monitoring their own condition using technology? So I guess it's about asking about some of the uses that you might see going forward.
Yeah, I think we've kind of touched on it a little bit already, but it's that amalgamation of all the different disparate systems and bringing that together. But we're already starting to see it in terms of personalised medicine with genomics that we've mentioned. Being the ability just to sequence a genome is relatively new, and obviously the cost of that is going down. Bringing in all of the other data that you've got in terms of the EMR, the medical literature, and the rest of it, and being able to make sense of that for a clinician. We have the abilities, or we're starting to see the abilities to do that already. So, it's absolutely fundamental as we move forward. And I think all of these questions are kind of interrelated, and the most important thing is transparency, as far as I see it, and making sure that people understand, what data is being used and what data is being trained on, and how their data is being used, and how they're going to benefit from it. So they're really great questions, and also just to touch on the previous question with that, for me, the more familiar we are as individuals with the technologies that are coming out, the hope that I have is that people will be much more, much happier to allow their personal data to be used, anonymised, of course, but their personal data to be used to help, clinicians to help themselves or help their loved ones as they're making decisions as we move forward.
And to come back to the original question of personalised treatments, especially for people with long-term conditions, Rose, is this something which is being explored in cancer care at the moment?
Yeah, absolutely. I think most of the discussion that I've been exposed to is about the, as I talked about before, the diagnostics and the maybe earlier part of the pathway. And then in the treatment space, it's probably more the acute treatment rather than long-term consequences of cancer. But I would imagine there is a lot of work. The other side of the good news of survival increasing is that people are increasingly living with cancer and it becoming more of a long-term condition rather than just something that is acute. And so I think things like chatbots, things that seek to improve patients' experience of ongoing care are really important. You could imagine with in a more cancer space, it might be more to do with side effects and long-term effects of treatment, people's fear of recurrence and wanting to understand any symptoms they're having. I can imagine there'd be a lot of opportunity there to make that process a bit more supportive.
Yeah, well, that's very interesting. Nick, maybe I can come to you about that question as well, about the potential for this in more personalised treatments.
Yeah, I mean, I think most clinicians would probably like to say that that all treatment they give is personalised. When they've got someone who they're caring for, they're trying to optimise the treatment for them. I think the key about this is about the sort of oxymoron of standardising personalisation. And so I think where the opportunity arises is kind of two ends of the spectrum. So one, it's about trying to identify from a multitude of factors. It's pretty hard to conceptualise with the normal level of most human understanding. Which are the patients that we can treat in a relatively standardised way and deliver the best possible care to them, and of course in that that they're happy with that pathway that they're on. So the factors that we want to play into that are all the medical factors that have traditionally been cared about, but it's also all the patient preference factors about the type of care that they want and the outcomes that they want to get, and how you do all those weightings between things. And actually you can do that in quite a powerful way with some of these technologies. The other end then is then being able to say, well, actually, what we do in that is that we then separate out and we say, the sort of 80-20 type rules of saying, actually, well, we're going to be able to standardise for a vast majority of people, but then really free up the expertise of clinicians to focus on the people who have much greater complexity, much greater needs, much greater uncertainty, much greater worry. That means that the limited effort that we have as a workforce can be deployed, in the best place at the best time.
So there's a lot of hype in artificial intelligence at the moment, but I've got a great question here which actually brings us right back down to the present. So Dave Price from NHS Wales Informatics Service, he asks, what are the quick wins in healthcare besides imaging for hospital with large amount of data? So lots of people talk about imaging. So, but maybe Ian, if I can come to you first on this one, what are the quick wins here?
So I can tell one of our quick wins, in that we have our chatbot. People can ask questions of it, and we have volunteers going around the hospital getting people to put questions into the chatbot interface, and we can analyse what's coming out of it. And the biggest question that's getting asked in our hospital is, where is G3 outpatients? And it's true. I went to the car park and I went to the main atrium. It's really not obvious where G3 outpatients is. We put a bigger sign up. G3 outpatients is this way. So that in itself was a very quick win, and that was through a natural language interface, getting people to ask questions that they're asking as they're coming in the door. Then at the back end, we've got something looking for themes of what's coming out. There you go. That's a nice quick win. So, and that's actually really useful, because if you've got people wandering around the hospital, and we did, because people think G3 is on the ground floor, they're trying to wander into operating theatres, it's on the third floor, they're going up to the wards, where actually the outpatients is, you've got to go round the corner and back, and then that's where it is. So you had people wandering around the hospitals, that's got to protect, that might have problems associated with it. So I think that's just a simple example of a quick win.
Definitely. Rose, maybe I can come to you on that question as well. Quick wins?
Yeah. So two parts to that for me. I think firstly, quick wins. I don't think it's cancer specific, but yeah, I think it is that more back office stuff that is a bit less flashy. Staff rotas being an example of this. That kind of thing that takes a lot of human hours, the more administrative side. The other thing I would say is that I know we talk a lot about imaging and there's a lot of potential there and there's a lot of demand for it. I don't think it's a quick win. I think comparatively to some of the broader scale, AI could do your entire treatment pathway, which I don't think is that realistic. There is still a lot of stuff that needs to happen if we're going to see AI used at scale in cancer screening, for example. So you'd need full digitisation of radiology and pathology, which isn't there at the moment. You'd need better access to training data sets. You need better pathways of regulation. We're still kind of in quite an early stage of that. Pathways for adoption, but also crucially diffusion across the system. And there's still quite a lot of stuff that needs to happen to get all of that in place. So that's the slightly trickier answer to that question is that while, yes, there is hype in imaging, and I think a lot of that hype's deserved, it's not to say that it's just coming around the corner and we could roll it out tomorrow like that if we had it proven to work in a particular indication.
And that actually comes on to a question which caught my eye here from Carol Munt, who's a patient partner and advocate. And she asks what I think is a really fair question. Bearing in mind the state of IT in the NHS, do we actually have the infrastructure in place to make the most out of AI? So Nick, maybe I'll come to you on this one first.
Sort of have to speak relatively diplomatically on this, I guess. We're on a journey, and I think it's a journey that's accelerating in terms of digitising the NHS. And it's no different to most healthcare systems throughout the world, so I don't think we're in a particularly worse place, but certainly not in a particularly great place as well. So there is investment that's needed. There's investment that's probably needed at a level beyond what's going in even at the moment. But I know we have some central plans to do that. But the question is right. It's the core of doing this, and the question to my mind is, are we going to be able to do this as NHS institutions, or are we going to be reliant on other external technology partners who have the leverage of resource and the incentive to try and help us with that? And I think that raises a bunch of concerns naturally amongst most people about whether that's done in the best intentions of the NHS. So I mean, I think the simple answer is we're getting there. We can do the basic sort of early stage quick win stuff. Are we going to be best placed to benefit from a sort of dividend in the medium term? Not unless we invest effort into building up our systems and focus on saying, actually, we need to start to curate data in a way that's going to feed systems. And of course, that then links to a bunch of strategic thoughts about how that can be valuable and can be fed resource back into the NHS by being shared more widely, and obviously, hopefully, improve patient care at a more global scale.
Yeah, and one of the issues coming up, but potentially the data curation is a way of solving that. But one of the issues that's coming up here is about bias, which we touched on already, particularly gender bias in data sets. So Emma Davis, clinical lead in the NHS, says some AI systems had a problem with gender bias, etc. The similar is likely to happen using current patient data. So how can we prevent it? How is that an issue that can be solved? And maybe David, I can come to you first on this one. How can we solve some of those issues in the data?
So again, I think it comes back to that transparency element of it in terms of understanding, and I guess we've all touched on it. Where the training, what data sets the algorithms are being trained on, where they've come from, what the population statistics are within those data sets, and making sure, I think, I talk about it with many different parties actually, given the disparate amounts of data and the disparate amounts of populations around, there's not necessarily going to be one specific algorithm or one specific set of data for that does everything. It's going to be a real kind of amalgamation of that. But I think we need to be very transparent in how we're doing it, what data we're using, and but then it's going to come down to the clinicians working to make best sense of it and to understand whether or not it's going to suit their populations.
So maybe Nick, I can come back to you on this one as well. So how do we make those data sets fit for purpose?
Well, I think we know that there's that issue, and so that's the first step on that journey. But I think it requires a development of maturity amongst the people who are potentially using, procuring, contracting for these sort of products to understand what the product you're getting is, and to be able to then decide whether, if it's just being curated on a data set of white men from the southeast of England, that's probably not going to be something that's going to be applicable more generalisably. So that's the key. I think it's about maturity, and that maturity then has to scale into the medical clinical workforce as well, because I think colleagues are being approached relatively regularly now with solutions, or seeing solutions at conferences and reading about them, and until we kind of train right from the very start, nurses, medical students, allied health professionals, to understand the pros and cons of these systems, then we're in a space where actually we can't really appraise whether a system being presented to us has been trained appropriately or not.
I sort of want to start to look forward a little bit here, and there's a really great question. One of the first ones that came in from Morad Margoum, Dorset Healthcare University Foundation Trust. She's asking, as clinicians, how do we go about accessing certain AI systems or experts to inform our treatment? So this is I think it's a really great question. How do we go about doing it? Like, what's the starting point? So maybe Ian, I can come to you on that first.
Yes, I suppose a lot of it is the interface that we're going to have in the room, and also, what sort of kind of characters you want to give it to. Because I've got a few ideas on the subject. Is that if you've got your doctor and they turn around and they start typing into a computer, there's almost like that bit of trust seems to get lost. Of like, oh, he doesn't know what he's doing. Why is he checking that? So how do you create a system by which you can consult an AI or some other kind of body of data without it coming across as, oh, they don't know what they're doing? So how can you culturally create these almost like kind of totems of knowledge? It's interesting how if you've got an Alexa in your house or a Google Home in your house, whatever, how people will ask questions, and that's almost not viewed in the same sort of way. So I wonder if you're going to start to have these kind of data points built into surgeries, into things which into a patient bedroom, that actually act as that repository of information, what you're checking against. And it comes down to trust again, and branding, and I think it'll be interesting as to how we actually access the AI. But it's probably not going to be through a keyboard and just typing questions in.
No, agreed. And David, if a clinician wanted to get started on this journey, what do they do? How do they get started? How do they go, okay, I want to start using artificial intelligence in my practice?
Yeah, I don't think it's quite as easy as saying, we want to start. I think the first thing is to look at the issue or the problem that they want to try and solve, and obviously oncology and cancer is a real primary one, certainly from an IBM standpoint, and primary one in all over the globe at this point in time. So it's looking at that. Obviously, there's lots of people that would be willing to talk around and give advice around what is available currently and where the market is moving to and what is needed in terms of collaboration. So, great points I think made in terms of imaging. Imaging's just not going to happen like that. We need the training sets. We need which companies such as IBM don't have. We need to collaborate and work with other organisations in order to do that, and it's going to take time to do it. So, but it's like any technology. Bringing it in because it's a buzzword and because it looks good and people want to talk about it is not the right reason. Is there an opportunity to use a specific data set that you have, or an opportunity to give the patients a better, better outcomes, better pathways, whatever it might be, utilising new technologies? That would be the first thing that I would say, and obviously, we would be happy to have that conversation, as with many others, but also talk to the likes of Ian and Nick and other clinicians who are very, very willing to talk about their experiences. Not wanting to put you on the spot, but we all go to these conferences, we all listen to the experiences that people have, and I think at this point in time, while the market is maturing and moving forward, those are what we need to be understanding. Where are the opportunities, and where can we get into?
And talking about learning from others, there are a couple of questions coming in about what the national picture could be. What should national government be doing around this to facilitate better AI in healthcare? Ed Fitzgerald from KPMG asks, internationally, Israel, South Korea and others are investing to build national health databases to harness the potential of the resource. So what would you like to see the NHS and UK government do to help deliver national benefit? So both health and economic, he says. So maybe Nick, I can come to you on this first. What's the role for national government in this?
Well, I think we're doing it. So I think now we've not got there yet, but we started that journey. We mentioned it a couple of times. The Leica programme to me seems to be the right direction of travel to bring together information at a scale and across domains of health and care that is relevant to help try and drive the benefits that we'd all like to get from better wellness and specific health. So I think we're on that journey, but that's not easy. And I think the big pressing issue, and we haven't really touched on it a lot, is issues about information governance, data sharing and privacy. And those are going to be discussions that we're going to really need to have with all of our clinical colleagues and organisations, particularly the smaller organisations who feel uncertain about how to navigate this landscape, but definitely with patients, because we have to realise that this is something of mutual benefit to us as a society, and therefore everyone has to have a stake in the game, because you need to be able to share your information but understand that that's going to be helpful to you ultimately. And so I think centrally national government's role is clearly to pump prime this with resource in terms of money, but also to give some clear direction as soon as possible about how we want to as a society embrace these sorts of technologies.
Yeah, thank you. And Rose, can I ask the same question of you? What would you expect to be seeing national government doing now?
Yeah, sure. So I've already touched on it a bit, but I think firstly, just to recognise that actually we're in quite a good place. So we always moan about data quality and everything like that, but the fact that we have the NHS that cares for basically the whole population means that we're kind of don't have to do as much as some other countries might have to do to get to that level. The cancer registry, for example, contains information on everyone that's diagnosed with cancer. It's population-based. It goes back lots of years. It's got data on 14 million historical tumours. So it's a really strong resource and it's a good foundation to build upon. But still, that takes a huge amount of resource to curate that data and to make it usable, and there's a time lag involved. So if we're going to use routinely collected data and apply AI to it, I think we need a bit of a step change in the quality of the data that we're recording so that it doesn't require that curation that takes several months. So there's some parts of that. I think what the government's doing really well is investing in research projects, early adopters, trying to really seed some of this exciting stuff. What I think we need to talk more about is the back-end stuff, about the data holding institutions like NHS Digital, Public Health England, making sure they're properly resourced, making sure, I don't know how to do it, but incentivising clinicians to input really high quality data, maybe giving them more access to that data to see the benefit of doing it. And also, all the information governance stuff as well. The final really slightly separate point, which I think is fundamental to seeing the impact of AI and the potential of AI realised, and also a lot of other things, is just giving people the headspace to innovate. Everyone's really busy in the NHS. It's a bit of an obvious point, but it's really true. And I think that impacts people's ability to do this really exciting stuff. So fundamentally, we need a less stretched workforce. We need more staff, basically.
Thank you. So I'm going to come back to each of you for one quick key message at the end. But firstly, I just want to go back to our polls, because we've got a final polling question just before we close up, which should be coming up on your screens now. So this question is which one of these challenges, in your opinion, is the biggest for your organisation? Linking disparate data together, presenting data in a way that staff can effectively use, working out who or what to benchmark against, accessing trusted data to support evidence-based decisions, finding a partner to co-create with us on our journey. And if you just select that, and we can go through the findings of that. I think actually a lot of those things are things that have come out in the discussion that we've been having anyway. So I think probably reflect the fact that these are valid. These are valid challenges, and that they are the ones that we're going to be facing as we go forward. So that poll should be closing. Your last opportunity. Okay. And okay, so I've got the results for that. So there's less agreement on this actually than there was for the last question, but the top one is linking disparate data together, which I think is actually probably the top one in terms of the number of times mentioned for the panel as well. The second one is with 28% of the audience said, which was accessing trusted data to support evidence-based decisions. So again, it's to do with that data access and actually problems in the data, not necessarily other things. And at number 3, with 21% of the audience, they've said presenting data in a way that staff can effectively use, which actually goes back to an earlier point, I think, that you were all making about the fact that this is about as much about upping the skills of your frontline clinicians as it's about anything else. So thank you very much for voting. So I'm just going to finally come to each of you, and David, I'll start with you just to give one final closing thought for our audience today.
Sure. I think actually the polls that you've asked have been really informative. I think in terms of the feelings of the audience watching, and I guess they probably replicate a lot of what we've discussed, which I think is really positive. But and this is a real moving feast, and it will continue to evolve as we move forward. So coming back to some of the questions, keep asking questions and keep understanding what people are doing, and kind of watch this space. And I believe that this will be, as I said at the beginning, a real game changer, and we need these technologies in order for us to move forward.
Thank you, David. Rose.
Yeah, it's difficult to sum everything up. It's been a really wide-ranging discussion. I think overall, just to reiterate, I think for cancer, we will see AI playing a role in so many different parts of the pathway. And some of that might be quick wins, but a lot of it will take a while. And in the meantime, what the government need to focus on, I think what we should all keep pushing for, is just getting the basics right. And it's not the easy basics, but it's the stuff that really needs to happen about data quality, data storage, information governance, privacy, and really critically making sure that patient impact's at the heart of everything, that patients are properly engaged in the process and all of that stuff as well. So that would be my main message.
Okay, Nick?
I agree. Data's key, but I think we're in a place where actually we're starting to understand what the elements that need to come together to be able to leverage this sort of potential is. I think my closing sort of reflection on it is this is a incremental journey that's ongoing. We're already a reasonable way into it, and it's just going to keep going. And I think it's not going to happen all of a sudden, but we'll find ourselves in 10, 15 years' time really looking back and saying, oh, actually we've changed quite a lot in terms of what we do. But in looking at that kind of time frame, I think what we have to do is look at the time frame of education and training of people in the health service, but also the general population, to try and be up to speed, if not ahead of some of the decisions that we're going to have to make about how we apply these technologies into our day-to-day health and care.
Great. Thanks, Nick. Ian?
Yeah, I think it's going to be really important for us to look up. We're really insular in the health service, not just the NHS, just around the world. If you look up and look at all these other industries, they're solving a lot of these problems. A lot of the answers are already there, and I think we need to learn from that. If you look at how people are driverless cars and the liability associated with it making a mistake, that'll be fascinating. We need to watch that very carefully. The travel and tourism industry, how do they do scheduling, how do they do booking, how do they do customer journeys, how do they make people feel comfortable with what's going to happen to them? So many areas there can be just picked up and lifted into a healthcare model. So I think that's going to be really important, that we make sure we don't just sit in our little hospitals thinking healthcare. We have to look at what's out there already.
Yeah. And I think this area is one that is so often overhyped, but actually today we've managed to keep it really focused on the here and now, really focused on not a year's time, but sort of tomorrow's time. And I think that's the real benefit of this. And it feels like the fact that we can do that means that we're hopefully coming out of that stage where everything is just hype, and actually getting into the delivery of this and how we can actually make it happen, which is really exciting. Anyway, thank you very much to my panellists today. It's been a really good session, really fascinating, and I hope it's been really useful for all the audience members out there. Thank you to all those who contributed questions. I'm sorry we weren't able to answer all of them, but there were so many we couldn't possibly have gotten through all of them. But those will be shared with our panellists after, so they can see the range of questions and the range of amazing expertise that we clearly had watching today. So thank you very much for tuning into this King's Fund online event on artificial intelligence. I've been Harry Evans. Thank you and goodbye.